on mortality. Second web package seeks to examine the sensitivity of birth and early childhood outcomes to climate exposure, leveraging a stance and well-characterized pregnancy cohorts that exist in Ghana. So that web package also is to quantify the effect of temperature on birth outcomes and child growth, where we'll be disaggregating by household, socioeconomic status, sex of the child, maternal education, and others. And we can say that this objective fits well into the broader aim, especially as there exists a knowledge gap between exposure levels for pregnant women in advanced countries and low and middle income countries. And the third web package, as we see here, is to engage policy stakeholders, communities, and researchers to amplify the visibility of research results. So I can say that what we are currently doing, the webinar series that we've initiated, falls under web package 3, where we are engaging the research community and discussing with you all the impact of climate change on health. Next slide, please. An important component of this project is the capacity building, where with the launch that Prof. Asante talked about, and I just mentioned the webinar series that we've just launched, and also we have, as part of it, we have also recruited 3 PhD students into the program, and the capacity building drive seeks to mentor and provide support to these students that have been enrolled onto the program to gain practical analytical experiences in policy relevant and climate-related research. And we're happy to mention that we have our fellows also on this call. They are also participating in this webinar. The project is a 3-year project. We started in 2014. We are just about ending year 1, fully set up. We have assembled data from the 3 research centers, Kintampo, Dodowa, and Avrongo. What we are doing is that we are currently doing analysis of the data. After successfully merging the data sets, cleaning them up, we've merged that with the climate indices as well, and we are analyzing. And we are also initiating manuscript writing. So the year 2, which will soon begin, we will continue with analysis and manuscripts writing, and we continue our engagement with the PhD students that we have enrolled to continue the mentoring. And we also be engaging in several stakeholder engagement activities. Then, principally in year 3, the final year, we hope to have outputs that we can show to policy makers, key stakeholders, the government here in Ghana, and by extension, also Africa, the whole of Africa, so that the countries can learn from what we have established here in Ghana. So, what is the focus of the webinar series that we have launched? As mentioned, is to build the capacity of the research community on the impact of climate change on health, and also to communicate the climate sensitivities estimates that will be generated from the CLARE project. We'll be communicating the results to audience that are interested in climate change. And also, we seek to build a community of practice of researchers that are engaged in climate aspects of research in Ghana and the whole of Africa. That's why the invitation is not limited to only Ghana, but across the globe. What should we expect next? after today's session. It's a monthly program, so we'll be having the next webinar session next month in April, 24th April. And the theme will be climate and malaria, where we'll be looking at modeling and also empirical evidence. And if you need more information about the CLARE project and the upcoming webinar that will be organizing, you can visit our website, that's KHRC website, and you can also email to the team in case you need any inquiry. But until we meet next month, and as shown in the agenda, and as Prof mentioned, we want to show you some of the studies that we conducting in Kintampo here, the outcome, the results of those studies, especially the impact of environmental exposures on health. Thank you very much for your attention.
Thank you very much. So we'll now invite Dr. Kaali.
Okay, thank you very much, KP and Japhet. So thank you for this opportunity to talk about the graphs, even though we're talking about climate change and health. But it's worthwhile to go back and start from where research efforts on environmental health began. So this was some 12, 13 years ago when the graph study was started. So by way of introduction, about 70% of Ghanaian households burn solid fuels in open fires for cooking. And this proportion is even much higher in rural areas. So the cost of this, so there's human exposure to air pollution and the myriad of health effects that we have, and household air pollution has been linked to increased risk for pneumonia, lung cancer, chronic respiratory disease, and cardiovascular diseases. And women and children are disproportionately affected just because of the traditional role of women in most sub-Saharan African countries, where women are the primary cooks in most households. This also has implications on deforestation and forest degradation, which is linked to climate change, and also climate change directly from emission of CO2 and methane from burning of biomass fuels. And lastly, it also contributes to gender inequality because women and girls spend time gathering firewood, time that they should have used on productive ventures or in school. Next. So the knowledge gap in household air pollution research, I will speak briefly about this. So we have prior studies that have linked household air pollution to morbidity and mortality across the life course. And globally, WHO estimates that about 3.2 million deaths annually are attributable to household air pollution. And this includes 11,000 deaths from Ghana. But despite this huge burden, evidence from previous randomized controlled trials on efficacy of clean cook stove interventions to reduce household air pollution and improve health is scarce and inconclusive. At the time that graphs was being set up, there were only a couple of randomized controlled trials that had investigated the efficacy of clean cook stove interventions on health. Now there's a handful, but the evidence is still inconclusive. And more studies are also needed to quantify exposure-response relationships between household air pollution and health outcome. There's still reliance on ambient air pollution and tobacco smoke data for modeling exposure response functions for household air pollution. So more research needs to be done in that regard. So talking about graphs designed, so GRAFS is a community-level randomized controlled trial of clean cook stove interventions in which 1,414 women were randomized prior to the third trimester of pregnancy to one of two cook stove interventions or a control arm. So the interventions included the BioLite improved stove, which burns. It uses fuel. It uses wood, firewood, but then it burns firewood more efficiently. And then the other intervention is liquefied petroleum gas stoves with monthly gas deliveries to the women during pregnancy. And these intervention arms were compared to the control, which consisted of the three-stone open fire, which is the traditional cook stove that we see in many households, especially in rural areas. So for the graphs, the co-primary endpoints were birth weight and physician-assessed pneumonia. So our goal was to determine the effect of these cook stove interventions on these primary outcomes. So exposure monitoring in the graphs. So we serially monitored carbon monoxide, which was the primary pollutant that was monitored in graphs. So in the entire sample, we did 4 prenatal sessions, and each session lasted for about 72 hours. And then we had the same strategy in the postnatal period. We monitored CO 3 times. So in the prenatal period and the postnatal period, we also monitored PM 2.5 in a subset of the cohort. So preliminary data that we had at the time showed a correlation between CO and PM 2.5. And PM 2.5 is more difficult and more expensive to monitor compared to CO. So CO was chosen as a primary pollutant at the time. Okay, so I'll share with you some data from the graphs. So first, the effect of cook stove intervention on personal exposure. So this intervention that was instituted, what was its effects or impact on personal exposure? So in the overall analysis, our primary analysis showed that the LPG intervention reduced carbon monoxide exposure by 47%. And similarly, LPG was associated with a 32% reduction in PM 2.5 exposure. So now relating the exposures to health outcomes, the primary endpoint of birth weight. So we found an inverse relationship between increasing prenatal CO and birth weight. So in the entire cohort, 1 parts per million increase in CO was associated with roughly 39 grams decrease in birth weight. And we also went ahead to examine sex-specific, to examine effect modification by placental malaria. So we stratified the sample by presence or absence of placental malaria, because placental malaria is also linked to poor birth outcomes, including low birth weight. And we found that this association was more pronounced in infants whose mothers did not have placental malaria. So infants whose mothers did not have placental malaria had that inverse association, so low birth weight with increasing, in association with increasing prenatal CO. And our thinking about these results was that placental malaria itself is a strong predictor of birth weight. So that might be masking the effect of household air pollution on birth weight. And so that's how come we didn't see this effect in children of mothers who had placental malaria. Okay, so moving on and talking about pneumonia. So physician-assessed pneumonia was another primary endpoint. And we recorded 381 physician-assessed pneumonia cases in the cohort over 1 year of follow-up. And a little above 100 cases of severe physician-assessed pneumonia in the entire cohort. So when we regressed pneumonia on prenatal CO exposure, we found that overall a 1 part per million increase in prenatal CO was associated with a 10% increase in the risk for physician-assessed pneumonia and 14% increased risk for physician-assessed severe pneumonia. And when these results were stratified by sex, we found out that girls were more affected than boys. So as you see in the plot to the right, the effect is more pronounced compared as opposed to boys. So we went ahead to then examine sensitive windows of exposure for birth weight and severe pneumonia. So this is basically, we were interested in identifying for the prenatal CO associations that we shown in the previous 2 slides. We wanted to know at what point in pregnancy are these exposures most relevant. And we found that for birth weight, higher CO exposures in mid-gestation between 15 to 20 weeks was associated with higher odds of low birth weight. And when we stratified this by sex, again, we saw this effect in girls as opposed to boys. So we used a similar approach for severe pneumonia, and we found a sensitive window in late gestation, so between 34 and 39 weeks. So during this period, exposure to higher levels of CO was associated with increased odds of pneumonia. Again, girls were more affected compared to boys. So for both modeling approaches, we used reverse distributed lag modeling, which allows you to determine time varying associations between exposures and outcomes, as opposed to the analysis in the previous 2 slides where we average the effect over pregnancy. Okay, so next we also examined the association between household air pollution and growth trajectories in the graphs cohorts, the children. So we had collected anthropometric data serially from birth until 12 months of age, so every 3 months in between. So we used latent class growth modeling to construct growth trajectories for the entire cohort for the various anthropometrics, so length, weight, head circumference. And the diagram you see here is an example of one such latent class growth modeling for length for age. So the model classifies the kids into 4 groups. So we have stunted, at risk for stunting, normal, and normal high. So we used ordinal logistic regression to determine the association between prenatal household air pollution and these growth trajectory variables. And we found that higher prenatal HAP exposure was associated with higher risk for lower length for HZ score, and stunting. So for stunting, for example, we found that so the odds ratio for stunting was 1.25, so 25% increase in the odds of stunting per 1 ppm increase in CO over the first year of life. And we also found that higher postnatal HAP exposure was associated with higher risk for lower mid-upper arm circumference and higher risk for wasting, a lower weight for length Z-score. So next, we also examined associations between prenatal household air pollution and infant lung function. So we carried out passive lung function testing in the infants approximately at 30 days of life. And we measured expiratory flow, we measured respiratory rate, and minute ventilation. And the plot you see here shows the inverse relationship between prenatal CO and the time to reach peak expiratory flow to total expiratory time. So this is a measure of airway function, expiratory flow. And we found an inverse association with this measure of lung function. And also higher prenatal CO was associated with higher respiratory rate and higher minutes ventilation. So what's interesting is that these lung function abnormalities at 1 month of age were associated with subsequent increased risk of pneumonia in the infants. Okay, so now moving on to the child lung function study, which is a prospective follow-up of the graphs cohort. So we selected a subsample of 700 mothers and children at age 4 for prospective follow-up because we wanted to learn more about the effects of household air pollution on lung function, on cardiovascular risks. So we are continuing to monitor air pollution exposure and then to perform these lung and other health measures. So the first result out of that is the association between household air pollution and lung function at age 4. And we found that LPG intervention was associated with better small airway function compared to control. And we used a similar reverse DLM model to identify the timing of exposure that is relevant for this effect, and we found that to be in late gestation. Next, we also determined the association between growth and lung function. So household air pollution was associated with poor growth, and then we wanted to see if growth also is associated with lung function. And we found that higher or poor growth was associated with worse lung function. All right, so next we determined the relationship between household air pollution and blood pressure. So we have resting blood pressure measurements at age 4 years, and we related the intervention in the prenatal and postnatal phase to later childhood blood pressure, and we found that LPG intervention was associated with lower diastolic BP Z-scores compared to control. So again, consistent with the previous findings, this effect was more pronounced in girls, and we also found that late gestation was the sensitive window for the outcome and exposure. So in conclusion, we've shown you the graphs design and methods, and then we've also highlighted key findings from the graphs, and we've shown that prenatal household air pollution exposure is associated with low birth weight and poor growth over the first year of life. We've shown that prenatal household air pollution impairs infant and later childhood lung function, as well as increases the risk for pneumonia in infants. And then we've also shown that household air pollution is associated with higher BP in children, but then the clean cook stove intervention LPG is associated with lower diastolic BP. We've also shown that poor childhood growth is associated with poor lung function at age 4. So recommendations are that we should be looking into potential interventions to arrest the poor growth, poor lung function, as well as higher blood pressure in the case. And one such intervention is nutrition, considering the mechanism underlying household air pollution and health outcomes. We've also included ambient monitoring, so we're not only doing personal household air pollution monitoring, but we're also doing ambient monitoring now. And yeah, we also are doing some mechanistic work, including genetic polymorphisms and transcriptomic analysis, as well as some biomarker work. So thank you for your audience.
All right, thank you, Dr. Kaali. So we'll now invite our next speaker, Dr. Alison Lee.
Thank you so much. And I'm really excited to share with you one specific analysis that we've performed within the GRAPS cohort, trying to understand associations between heat and humidity and birth outcomes. So Dr. Kaali just gave a really nice overview of the GRAPS cohort. So I don't feel I need to go into too much detail here. These analyses are focusing on almost 1,200 pregnancies in which we had complete data around birth outcomes. And also we had ultrasound derived gestational dating. This was critically important because for these specific analyses, we leverage satellite estimated heat exposures in a 5-kilometer grid. So essentially what that means is for each participant, we know where they lived when they were pregnant. And then we can take contemporaneous satellite data and link it to that location and understand on a daily resolution what the temperatures were each study participant experienced over pregnancy. And, this approach is a really exciting one that all of you listening potentially could think about doing within your own cohorts or existing data sets. Really, what you need to know is where the participant lived and then key dates to be able to apply these methods. And this is just to show you for our study participants, for the communities in which they lived. These are temperature trends starting in 1983, which was the start of our available data set for the satellite-derived temperature measures through 2016. And you can see that the colors here are showing you temperature, with darker red being hotter. And what I'd like to draw your attention to is just over time, the temperatures do appear, on a monthly average, do appear to be getting warmer, again, across these study areas in Ghana. If we look at this as well, thinking about extreme heat events, which we're defining as a wet bulb globe temperature max, which is a humid heat measure over 30 degrees Celsius, what you see is that moving from 1983 to 2016, there definitely appear to be, and this ends up being statistically significant in different statistical tests that we ran, there appears to be a trend where there's just a higher number of these extreme heat events as you progress across time. And so again, what we're able to do is we're able to, using our ultrasound gestational dating, where we can define the date of conception through the date of delivery, we can then generate temperature exposures, wet bulb globe temperature exposures for the duration of pregnancy, and try to relate those using statistical models to different birth outcomes. And so here what we're looking at is associations between trimester average wet bulb globe temperature and birth weight, shown in A, birth length in B, and head circumference in C. And what we see is that higher temperatures, particularly during the second trimester, are associated with a reduction in birth weight. And this is per 1 degree Celsius increase in wet bulb globe temperature. We see a reduction in birth weight. We see a reduction in birth length. And then trimester 1, trimester 3, and then averaged across all of pregnancy, we see that higher temperatures are associated with higher head circumference. We also looked at small for gestational age. We looked at low birth weight and preterm birth. We did not see associations between temperature and risk for small for gestational age or low birth weight, but we do identify that pregnancies that experience higher temperatures, particularly during the second trimester, are at increased risk for preterm birth. We then, using the daily resolved wet bulb globe temperatures, we were able to employ distributive lag nonlinear models to understand associations between temperatures at the 25th percentile, which was 26 degrees Celsius. Again, this is the wet bulb globe temperature measure, or the 75th percentile in relationship to the median, which is 29 degrees Celsius. And essentially what we see when we look at birth weight and birth length is this clear signal that cooler temperatures are protective. In other words, that cooler temperatures as compared to the median are actually associated with increases in birth weight and increases in birth length. And when we look at the median of 29, the median was 27 as compared to 29, what we see is a suggestion of a window here, but nothing really that reaches statistical significance. So in other words, our conclusion from these models is that compared to median wet bulb globe temperature, what we see is that cooler temperatures do appear to be protective for lower birth weight and shorter birth length. And so in conclusion, we do identify associations between temperature, specifically that higher temperatures appear to be associated with worse birth outcomes. Again, associations with birth weight, birth length, and preterm birth. We do see an association over pregnancy with higher head circumference. And this is all really on the background of seeing an observed trend for higher temperatures and more extreme heat events in the study area over time. And we see in the distributive lag nonlinear models, in fact, that cooler temperatures appear to be protective as well. And so I think something for, perhaps to sort of stimulate some thoughts in the audience about where we can go from here. I think this is a really feasible approach that could be leveraged in other cohorts, specifically cohorts that have dates, whether it's dates of outcomes. For things like pregnancy, you'd want to know sort of the date of delivery, perhaps the date of conception if you have those data. But then there's really an opportunity here to apply these satellite-derived models across Africa to these different health outcomes to answer critical climate and health questions. And doing so in the context of trying to build research capacity, which is really a critical aim of the project that's being described today. And so thinking about this for the larger group, I would encourage you to think about how can we expand outcomes and how can we really start to build a consortium across Africa to really fill data gaps that exist currently with regards to climate and health sensitivities. And I also just really want to take a moment and recognize and acknowledge Dr. Abubakari for his contributions and leadership, not only to the GRAPS cohort and this current project, but really to the scientific field more broadly. So I'll pause here and hand it back to Dr. Asante.
All right, thank you very much to you, Japhet and Kaali, and then Alison. So we'll open it up for comments or questions. kindly raise up your hand. You'll be given the opportunity to speak and or put in the chat if you don't mind. So whilst we wait for others to say something, Alison, for the interest of the participants here, can we say a bit more about where and how the temperatures were derived for the analysis, heat exposure analysis?
Right. So for this particular analysis, we're using, as I mentioned, we're using a satellite-derived temperature measure. We're using wet bulb globe temperature, a daily maximum level. And these are available. And again, our team in Kintampo, Dodowa, Navrongo, sort of across the consortium with leadership from KNUST, and our colleagues at Montana State University are essentially pulling down these gridded data sets that, as I mentioned, go back to 1980. And so for these analyses, we're using wet bulb globe temperature. There's a number of other variables that are available as well. And we have these data, daily resolution, as well. And so that's how we were able to apply them to our cohort, where again, we knew where the participants lived. We knew the date of delivery using our ultrasound measures. We knew the date of conception. And so essentially what we're able to do is we're then able to pair each participant to the satellite derived measures in the grid, where they lived, really for each day over pregnancy. And I think this is something that definitely could be replicated for other cohorts, for other existing cohorts, where you don't have to have, temperature monitoring at your study site ongoing for the duration. I think as long as you know where your participants live, and then the time frame, and our team, again, we're building this capacity, and KNUST clearly already has expertise in this area, to be able to help people link data sets and work on similar analyses. Darby, I see that do you have anything to add on that about availability of data and ways that it could be leveraged?
No, that was a great summary. The only thing I'd add is that these are all public use data. They do require some expertise, but the team is developing that expertise locally, and they're all open data.
So just to add that very soon, probably in the next couple of weeks, we would have this located on the Kintampo Health Research Center website, so that publicly available data can be accessed. So we've talked a lot about the GRAFS cohort and spoken about doing all these sampling at various time points, and it sounds very interesting, very successfully done. But I would like us to discuss any potential challenges during the conduct of these studies. And I'll start with you, Dr. Kaali.
Okay, thank you, KP. So the GRAFS cohort has been ongoing for over a decade now. So, if you have a longitudinal study that's been going on for that long, the first thing that comes to mind is retention. We are grateful to the communities and the participants for staying in the study. We have good retention rates, but then sometimes over the years we've observed that sometimes that rate goes down a bit, and we have to intensify our community engagement activities. We have to try and reestablish communication and rapport with the communities and the study participants to get them back on track. And in the graphs, there are several measurements that we do. So the air pollution measurements, personal air pollution measurements, which involve wearing of these devices close to the breathing zone. So even though we do this at specified time points, but from the perspective of the participants, it gets to a point where they feel over familiar with the devices and compliance becomes an issue. So we have to continuously engage them. So other challenges relate to so the field challenges in general in doing this kind of longitudinal study. So meeting the study participants, especially during harvest seasons, so you have to strategize to go to the field early to meet them, to perform your measurements. Yeah, so these are some of the things that come to mind.
Great, thank you. The other question that probably is on the table is then what types of cohorts do we envisage to be present in the health system or with other studies or anywhere else within Ghana, also in sub-Saharan Africa, that can be leveraged? Maybe any of you can speak about some of the cohorts like the demographic and health survey that does exist in any other ones, or the demographic surveillance system. Dr. Kali, do you want to take that?
Okay. All right. So, yeah, so we have the DSS in Kintampo and in Avrongo and in Dodowa. So we have these very well placed, well located across the three ecological zones of Ghana. And these DSS centers have been running for several years now. So we can have data going back as far back as 15, 20 years. And the DSS primarily tracks migrations. So that's something that can be thought of and something that we've spoken about in our groups, where we could look at the effect of climate change on um, migration, whether climate change is driving populations to move from the north down south. So that's something that can be thought of. DSS also has some health endpoints, some health data that can be combined across the three centers to look at effects on climate. And so the locations of these centers is quite well suited to climate research in terms of the differences in climate, although the experiences might not be too different, but there are still some differences to study health effects of climate.
All right, thank you, Dr. Kelly. I see we just have a few minutes to go. There was a comment in the chat around, says, with regards to the number of deaths, where do they occur in Ghana that are due to climate change?
I can take a stab at a sort of first pass for this. So for the work package 1, which is leveraging, as Dr. Kali mentioned, the HDSS across the 3 health research centers, those analyses are ongoing. So what we've done at this point is we have sort of collected the data from the 3 research centers, we've harmonized the data, and we've brought them together. And then we've linked to the temperature data set. And we're just now running the analyses to understand that link between heat exposure and mortality. I think, what is also interesting about the HDSS is that there's a number of other variables, as Dr. Kali was mentioning, that we could potentially also think about sensitivities. So for example, within the HDSS, I say for the majority of deaths, we know age. So we could understand whether that sort of heat sensitivity varies by age. If we think of the very young or older community members, those may be, according to the existing heat literature, those may be groups that may be particularly susceptible to heat. We can also look at factors such as household wealth. So thinking about asset index, which is sort of an enumeration of household variables, again, which is collected across the site. So for people who are thinking about, similar analyses within their own context and potentially within different countries and different HDSSs, I would also encourage you to think about those modifying factors that could be really interesting to look at. So that's a long way of saying those analyses are underway. I think we've made really nice progress on sort of bringing all the data sets together and getting them into a workable format. And we're hoping to really finalize those mortality analyses in the near future.
Thank you. So for Japhet, there's a question around what's the plans for dissemination. Japhet, do you want to take that, please?
Thank you, KP. So for this study, what we intend doing is to organize community debates where we plan to have some drummers organized in the various communities to sensitize them about the impact of climate change and also to disseminate the result from the study. We also intend to communicate that through the radio stations that we have, the local radio stations that we have, and the community of researchers to, as we mentioned, we will do that through this kind of forum where we let the scientists know about the real impact, the estimated impact of climate change on health. And we'll also be organizing national level stakeholder engagement where we also solicit their views, and together we think of the way forward, and especially when we are engaging policymakers on the results of the study. So these are some of the ways through which we will communicate or disseminate the results of the study to the communities.
Okay, thank you. So we're just about out of time, and I would like to say a big thank you to all the presenters here today, and then to the organizers for doing this, and also to the study collaborators for this. We are just seeing a slide here, which is just an advert. This is another initiative that we are engaging in, which is NCD, Environmental Research Strengthening and Training. This is a training program, and there are adverts that have gone round to solicit for trainees. The first round is ended. The second round is likely to start next year, so please keep an eye on it. So I just want to end it here. It's just about 3 o'clock. Thank you very much, Solomon. So without any further questions, thank you all very much for your time in preparing these slides, and thank you all very much for attending the session. And we'll end it here and look forward to the next presentation, which will be on the 24th of April. Key reminders will be sent along that line. Thank you all very much, and have a good day.
Thank you. Bye.
Bye-bye.
Thank you.